Let me start the demonstration of this, how the needle are placed and how the cord. It will not be the same exactly what will be done in the patient. I'll be showing you the patient video later on. This is the caudal end. This is the cranial end. Okay. So two cameras are there. One from the head end, which is a little bit of longer shot, another from the caudal end, so that you can appreciate the needle placement very nicely. And first of all, you see how is the needle. You see the needle tip. Needle tip is, I'm just taking it in front. So the tip is, you see, tip is widely open. Why? Because in the two-way needle, you see the tip is widely open. So in the two-way needle, we cannot take the catheter back, but here we can take the catheter back. So this is the difference between that. And as Dr. Series already told, that normally we start entry point at 1 to 2 level below, 1.5 to 2 level below, and the angle means this angle should be less than 30 degrees. Why? Because when we put it, this is a spinal stimulator lead. So you see the electrodes are inside that. Otherwise, it looks like an epidural catheter, but the leads are there inside. Means electrodes are there inside there. All the glistening things are with electrode, and each electrode is insulated. Within that, this is an octopolar lead. 8 electrodes are there inside, and all the electrodes have their connections individually, insulated connections within this same together. So only putting it, if it angle is much more, it is going to do the dural puncture, and also you cannot steer the catheter nicely. So first, most commonly for the lower limb, what we have seen, lower limb, our catheter should be somewhere in the thoracic area. Means lead should be somewhere in the thoracic area. For that, the most common entry point is at the level of the T12L1 or L1, L2. So that is the common area. In the actual patient's video, we have entered the lead one at the level of the L1, T12L1, another is at the level of the T11, 12. So the other areas, most commonly T12L1 is the area. Here in this patient, let us first count the levels. So you can see this is your picture. So this is your L1. Above that T12 we can see. So the T12L1, if I want to enter the epidural space at the T12L1, so I should be putting my needle at here, picture, at this level. This is L2, L3 level. L2, L3 level is my needle entry point, and I'll be going into the interspace between T12 and L1. So it is approximately the 2 segment, 1.5 to 2 segment below. Another very common question is asked, why can't I go in the midline? Like you can understand that the spinous process is already, if I'm putting my needle in 30 degrees, what will happen? I'm always going to hit the spinous process. So I cannot go in the midline, because then you cannot make the angle 30 degrees or less. So now I'm putting my needle entry point here, picture. So at this point, I am putting, this is at the level of the lower end of the L2. And my final target should be touching the L1 lamina. So this angle is less than 30 degrees. So, and also little bit of below the pedicle my skin entry point. And then finally, what I'll do, I'll touch the lamina on the side of the spinous process. So once I go at the level of the L1 lamina, at this point, I'll be increasing this angle little bit, and then advance further, because my intention is to touch the L1 lamina. So at this point, I'm touching the lamina. Okay. So now once you're touching the lamina, then again decrease the angle. And now you walk over the lamina, keeping the touch and slowly advancing towards the midline. So now I'm walking, I'm touching I'm keeping the hub upwards, the bevel upwards. And I'm touching and I'm going. Okay, so at this point, when I'm at the edge of the lamina of the L1, at this point, I should start LOR. Here in the mannequin, I cannot demonstrate the LOR. So, but at this point, I should be going on the lateral view. Because even if I'm superficial, then also I'll be getting the similar kind of picture, though I'm touching the bone there. So you have to keep touch on the bone. That is very important. And on the lateral view, I have to understand exactly where I am. Okay, so you see, I'm touching the lamina there. I'm the upper edge of the lamina. And now at this point, I'll be advancing the needle very slowly and doing the LOR picture. So once I have entered into the epidural space, so here I told you I cannot show you the LOR here, but and at this point again we check by the AP view. So what is important here? This angle should be less than 30 degree or less. Picture. So I'm close to the midline. I'm in the right position in the AP also. At this point, what I should do, I have already done the LOR. Then the next thing what has to be introduced is this Guideware. So this is a Guideware. You see, this is a Guideware, state Guideware, and because this is to thread and create some space there. So though here there is no spinal cord, no epidural space, typical advancement will not be there. Picture. So so once your Guideware is there, then you take it out and you insert the epidural, the spinal custom-rotated lead. Picture. So here again, you are not going to get it is in the epidural space. Posterior epidural space I'll be showing you on the catheter, on the real patient's video. Now tip, you see the tip can be changed. You see picture. See the tip, I can change the tip by rotating this. By rotating this, you see, I can steer it. Picture again. I can steer on the left and right side by rotating it this tip. This is how which I can steer it, and I can go to the either right or left or straight. And if you are going sometimes accidentally to the anterior space, here in this I cannot show you the lateral view. In the lateral view, I cannot show you the anterior and the posterior space, but in the real patient, where the anterior space, posterior space is there, we have to keep always in the posterior space. Here I cannot show you that this is going to the anterior space, 16, but in the real patient, because there are epidural space, so you can thread it more towards your posterior space. Posterior space means, I'm just showing you here by drawing, which is the posterior space, which is the anterior space. So it should be here. This is the posterior space, and this is the anterior space. So here, because I don't have any spinal cord, so I don't have any anterior or posterior space. But in real patient, it should not come like this. It should be coming like this. So, and then you have to go to the desired place, and that you will complete the procedure. So you understood? This is like an epidural catheter placement, simple anesthetic epidural catheter placement. But the difference here is we are not going perpendicular, and also we are.
Explain that anterior and posterior once again. Sorry to disturb you. The same thing. Just 2 sentences back.
What?
You draw the lines, no, sir. Anterior and posterior. From there, you just explain me, sir.
So the epidural space or anterior epidural space. Suppose this is your spinal cord. Okay, the spinal canal. Dura is there. So anterior to the dura is this is your anterior epidural space, and posterior to the dura this is the posterior epidural space. You know, no? This anterior epidural space, posterior epidural space, lateral epidural space. So the spinal canal, within that, what is there? Spinal cord and surrounded by the different meningeal layer. The outermost meningeal layer is your dura. The epidural space is what? Epidural space is the space between the dura and the spinal canal. So how many epidural spaces are there? Anterior, posterior, and lateral. 2 lateral epidural space. So when we are, and this space is continuous. Here I am entering through the posterior epidural space here, but the catheter can curve and the tip, and it can go to the anterior epidural space, or it can go to the lateral epidural space or posterior epidural space. So our intention is to keep this in the posterior epidural space, not the anterior epidural space. Is it clear? Here, because I don't have any spinal cord, everything is epidural space. So in the spinal canal, so it is going anteriorly. But in real patient, what happens? I'll be showing you in the real video. Is it clear to everybody?
Okay, thank you, sir.
So this patient had surgery several times, 3-4 times. So screw plate implanted, removed, again implanted, and you can see the plate screw there, the disc is there, artificial disc is there, and the patient was having pain. Motor deficit, sensory deficits was very mild, not that much, but patient was having the severe pain. So here, as we mentioned earlier, the fixation was done from the L1 until L5. So we'll be putting, patient was having the bilateral symptoms. One side symptoms is more, but the patient was having the bilateral symptoms. And we plan to put the electrodes on the either side, both on the left side and the right side. So you see, initially you are putting this is what I do, that when I'm giving local anesthetic, I take a spinal needle and I determine the path, how it will be going. Means with the spinal needle itself, I try to touch the lamina here, the 2 segment above the lamina. And then you are putting this is the RX chord needle. So this RX chord needle, this is the area of the interlaminar space. So you are hitting this lamina, you are trying to go at the level of the T11, T12 interspace. So this space is our target, T11, T12 space. So trying to go towards the midline. So we touch the T12 lamina, not L1 lamina, and then went above to find out the space between the T11, T12. So once we are at the edge of the upper margin of the lamina, then we should start the loss of resistance, LOR. And so this is the LOR we are trying. So you see, this is the anterolateral space. Somebody was asking, this is the anterolateral space, just posterior to the vertebral cortex. And this is the posterior space. So our catheter should be at this level, not here. But sometimes it can curve. So LOR was completed. So we could understand the LOR. And now we'll be putting the Guidewire first. You see, this is going anterolateral space. So we have to take it back. And again, we have to redirect it. So now we are putting the spinal cord stimulator lead. Now it is going to our intention is to put it on the left hand side, but it is going to the right hand side. So we are again taking it back. We can use the bevel side, right, left, anterior, posterior to redirect the lead. So what we are doing here, we took it back, but still again, you see, the lead is going back. Now it is going in the posterior space. You see, initially it was in the anterior space. Now this is in the posterior space. And we are also checking where we are going. Though it is in the posterior space, but the lead is still going to the right hand side. Our intention is to keep this lead, left hand side lead to the left hand side, but it is going on the right hand side. So we are taking it back and again redirecting it. So by this trial and error and the steering, we are trying to put it on the left hand side. Again, it is going right hand side. So this we have to, and with the help of the stellate, this is the stellate. So here by rotating the stellate, you see I am rotating the stellate to steer the tip of the catheter. So now it is going to the midline. So now we are happy. So now we can redirect it towards the left hand side also. You see how you are redirecting it. Now it is going to the left hand side. So now it is going to the desired place. So now it is in the midline and little bit on the left hand side. So also we are checking it whether it is in the posterior space. So now you can see this is the anterior space and this is the posterior space. So our catheter is, our spinal cord stimulator lead is perfectly on the posterior space. So we are happy. but we are trying to put it just side of the midline on the left side of the lamina. So that is our desired place. So now we are happy with the lead placement. So now we are trying to put the lead on the right hand side. So similar way, so our needle entry point, skin entry point should be 1 or 2 segments below. And here, so this is our needle. Here is our needle. And our target is, we are already there at skin. Our target is this epidural space between the T12 and L1. Earlier, we entered at this space between the T11 and T12. And here on the right hand side, we are trying to put it on the 1 segment below at the level of the T12 L1 level. And then in the similar way, first we are putting some Guideware and create this path, create the space, checking by the lateral view also to see that whether our the Guideware and the leads are going in the posterior epidural space or anterior epidural space. So now we are threading the stimulator lead and we are checking it where it is going. So it is in the posterior epidural space and it is in the right hand side. So now again we are steering and we are trying to keep this lead on the right hand side just close to the midline. So we are advancing the needle. Tip, we are keeping it at the level of the one side, we are keeping it at the level of the T89, another right hand side, 1 segment below. Again, these are determined based on the patient's area of the pain. So my lead were going towards the left hand side. So again, with the steering by rotation of the stillet, I'm redirecting it to the right hand side. And now, again, right hand side, left hand side, I lead, and also checking by the lateral view to see. Now you see the leads are very nicely in the posterior epidural space. So we checked it once, and again, repeatedly have to check that you are in the epidural space. So we are pulling it back and again trying to put it little bit on the right hand side, little on the lateral side. So now this is going nicely. And if it is like a V or the vas sepid, V sepid, then this is the best placement of these things. So just side of the midline. This catheter on the left hand side is very nicely placed, and on the right hand side also you used to place it in the similar way. And 1 segment below. So this is the area we are happy with this placement. 1 on the right hand side, 1 on the left hand side of the midline. And once we are happy and satisfied with the lead placement, then we'll be taking the needles back, RX cord needle back. So we are checking it finally. Normally from the desired place, and we are counting the vertebral body level, we put little bit up so that if during the removal of the RX cord needle, there might be slight displacement, that has to be taken care. So this is the final position. Depending on the area of the pain, we are putting it. So 1 lead we have kept at the right hand side, you have kept the little tip at the T9, upper part of the T9, and the left hand side you have kept it at the level of the T8. And then we are putting the local anesthetic around the needle to create the space, a subcutaneous pocket. And then small incisions around the needle. And then we are taking the RX cord needle back. So RX cord needle back. And the stillet also removed. First on the left hand side. And then we'll be removing the needle also same way on the right hand side. Again, we are putting the small incisions there, because we have to create space and we have to put the catheter inside the subcutaneous place. The needle is a guard. Once you are removing the needle, it is difficult to give a incisions around the catheter. So that is the reason small incisions to be given around the needle. And after you are removing the needle, then you can increase the incision and put it there in the back. So this is your spinal cord stimulator lead placement.